It's a pleasure to be here. Thanks to Hamid and thanks to Colleen again for the invite. I wanted to mention that the content of my talk is going to be solely derived from the NIH NIDA sponsored contract. Will is the program officer. So moving along. I wanted to start off with some caveats. The title of the talk is How to Work with the FDA to Design a Trial. The focus obviously is just going to be on marketing and pivotal trials. If you are going to be having a discussion with the FDA for an IDE, obviously the discussion is going to be completely different. And again, just to reiterate, my content is going to be based on our experience and interaction working with the FDA and specific to our use case, which is cocaine use. Intended use, while this is obvious, right, it informs the study design as well as the most appropriate regulatory pathway to pursue. For devices, as you know, is the De Novo or the 510K. But it is extremely important, and I'm going to actually go through some scenarios, and I'm going to try to sort of emphasize how thinking through the intended use is extremely important, especially when you're working with the FDA pathway in your mind. So on a high level, there's no restriction. You can essentially pick anything, right? But what you need to do, especially from a therapeutic standpoint, right? We're not looking at diagnostics over here. We're not looking at preventing something over here, right? So from the therapeutic standpoint, you have to include a claim to treat a condition. Sounds pretty easy to frame and put together. So I'm going to go through some scenarios as I explained. This is again in context of our grant. So we reached out to the FDA and we proposed the intended use, which is basically XYZ device is indicated for the cessation of cocaine craving. FDA's feedback was that craving is not a good claim. The reason being that it's neither necessary nor reliably, so reliably is important over here, predictive of relapse. Craving is purely understood. It could mean a whole lot of things, want, urges, and craving, while helpful in isolation, is not sufficient. And again, this is just to show you, you may have already seen this in different ways and forms, but again, this is just to reiterate that when you are drafting this intended use, there are multiple things that you have to keep in mind, so to speak, right? Patient population, things are going to be different for inpatients versus outpatients. Things are going to be different if you do things at home versus doing things in the clinic. And your intended use really has to reflect that. And once you have the intended use in mind, then the clinical study endpoints really have to collect that relevant data, right? That's really what the FDA is looking for. Are you able to make claims that you can support through the clinical evidence? There are other layers to the intended use. The intended use should confer clinical significant benefit, should be clearly attributed to a device. Again, we'll go through some examples. So we reframed our intended use. We said, okay, XYZ device is intended for cessation of cocaine use. You'll see that the craving has been replaced with use now. FDA said that this is reasonable, but keep in mind that you have to demonstrate abstinence for 12 weeks. And this is when the FDA pointed out that, listen, you don't have to necessarily think about abstinence. You could think about cessation, or you could just think about reduction. It doesn't have to be just stopping use, because it could be a higher bar that you're setting for yourself. And this is when the FDA pointed out that you should think in terms of 4 days of use. I will get to that in a little bit, in the final month of the study. And this is when the FDA pointed out to this public workshop. I believe at some point today, this workshop will be mentioned. This is on the Reagan-Udall Foundation. Extremely helpful. It's a public set of slides. I highly recommend everyone to look at it if you have not already looked at it. The set of slides by Dr. Killock from Yale University was really, really helpful, because he mentioned over here, clearly this was taken from a draft guidance document, 2018. It's not in draft form anymore. Basically, he mentioned that abstinence is not required as an endpoint, again, from the draft guidance. But what is important is that to show that you have to show clinical benefit, right? It's really from the perspective of the of the patient, right? And showing that the change in drug use pattern does predict clinical benefit. So this is a key point. And basically, the slides had data, basically pulling data from multiple RCTs, showing that absence of physical and psychosocial problems is indicative of clinical benefit, right? So if you're able to basically look, again, from the lens of the patient, think about problem-free functioning, which relates to cocaine use, you may have a better intended use. The slides also mention things like frequency, right? So low frequency use is defined basically less than 4 cocaine use days in the past month, and high frequency use is any number higher than 4. And basically what is important to note is that reduction from high frequency to low frequency in terms of benefit to the individual was very similar to high frequency going to abstinence. So FDA's feedback now started making a lot of sense to us that yes, we don't have to necessarily pursue cessation. It could be changing of days of use of the substance. Moving on to right primary measures. Again, many of these things are obvious, but I'm just re-emphasizing and reiterating some of these things. Keep in mind that the outcomes should be practical and should have a noticeable effect. Objective measures are actually always preferred. The assessment should also include a clinician's assessment of function. Like function is extremely important. And keep in mind, especially in addiction research, and universally accepted, MCID is clinically meaningful important difference. It may not exist for your primary measure. But that's not the end of your research. I mean, if you think that you have a validated instrument, you have collected data, you can present that case to the FDA, and then you can have a discussion with the FDA and try to justify why you think that your measure should be an important outcome. And again, clinical meaningfulness is central because, again, when the FDA says clinical meaningfulness, they are essentially looking and considering both from the lens of the clinician and the patient's standpoint, and ideally coupled with an objective measure because you would need that. So urine drug screens, you would be required to perform this in some capacity. It's an objective marker. But what essentially ends up happening is that timing the frequency becomes extremely important, and you may necessarily not have had the budget going in to do this correctly or do this in a way that satisfies FDA's requirements. So again, from the cocaine use case perspective, we have gotten feedback that the weekly collection is likely sufficient, but implementation could be a challenge. So this is an example of our ongoing phase 2 clinical trial. Dr. Goldstein, she's here in the audience. She's leading this clinical trial. We are working with inpatients. They're there for 12 weeks. They do not start off with, we are using transcranial direct current stimulation, though they don't start off with TDCS right away. It takes some time to get them enrolled into the study, and obviously taking weekly screens is not meaningful because there's no signal. They are at the rehab facility, right? So now when they are discharged and now you want to collect weekly screens, that leads to high attrition, right? So again, going back to patient population, how do you want to design their trial? Taking into fact FDA's feedback and what they're looking for is extremely central. Study timelines, obviously beyond safety and efficacy, if you're landing on co-primary outcome measures, then obviously both have to be successful. Make sure that both timelines match up in your study design. FDA is looking at multiple different things: robustness, durability. Is it a short-term effect? Is it a long-term effect? And if things don't line up, then what do? I mean, you then have to change your intended use. You just go back to the drawing board. How do you balance this? Now, there was mention of several RFAs, NOFOs. These NOFOs explicitly mention FDA. And this was mentioned, researchers should make it a priority to obtain pre-submission feedback. So this is basically an application that you submit. Basically, you get a written feedback, which is basically something that you can use now to plan your clinical trial design. Extremely helpful, especially when you're looking to move devices to the FDA pathway. Now, how do you harmonize these measures? So one strategy could be that if you can pull this thing off budget-wise, you could collect a range of measures. And you could basically use one set of measures to have a peer review discussion, and you could have another set of measures to have the FDA discussion. Common fallacies, we still see a lot of trials. Keep in mind, FDA considers adults to be the age of 22 and above. So if you're not, if you're planning a trial with 18 and above, then you will have to remove a subset of your population. Relying on past pivotal study designs. Always make it a point to talk to the FDA because FDA is always using the latest thinking. So what I mean over here is that if you look at, let's say, an approval from 2022, right, and you simply base your design based on that, thinking that, okay, this is what the FDA allowed in 2022, they should likely allow right now. Well, not really. You should always have a discussion with them and get confirmation on that topic. Data presented in the pivotal study publications. So this is the actual data from the journal publication. Refer to public summary statements, because keep in mind, they have gone through different review processes, right? When you are submitting a pivotal study publication, you're going through a journal review, whereas in the summary statement, data is presented in a fashion that resulted in the regulatory decision-making. So extremely important. Try to look at both. And again, don't make any assumptions, talk to the FDA. Last slide. Refer to public documents. There are a bunch of guidance documents. If you're in the device world, look at the drug ones as well. If you're in the drug world, look at the device ones as well. Summary statements or relevant technology is extremely helpful. We have looked at a lot of, brainwaves, smoking cessation, summary statements. Look at workshop slides, the ones that I just mentioned. Harmonizing FDA's expectations requires careful rethinking and replanning of designs, but it's possible, requires motivation. And keep in mind, again, FDA will consider a lot of different factors: persuasiveness, robustness, seriousness, which is especially important when there's an unmet medical need, where there's ethical, practical, conduct more trials, and speak to the FDA. And thank you, everyone, and thanks to Dr. Alia Klein and Rita Goldstein from Mount Sinai.